Bismillahirrahmanirrahim. We will start with the quote of the day, which is by Hazrat Muhammad sallallahu alaihi wasallam. But if he must eat, fill it, then one third of food, one third for drink, and one third for air. My name is Dr. Taimia Ayub. I will be presenting today the topic obesity under the kind supervision of Professor Dr. Saira Afzal, Dean, Institute of Public Health, Lahore. So this is the outline for today's presentation. We will start with the learning outcome, introduction, definitions, and classification, followed by pathophysiology, etiology and risk factors, different signs and symptoms, diagnosis, management, and then we will apply levels of prevention for the control of obesity, global burden and national burden of obesity, followed by recent advances, and at the end we will be doing MCQs. So these are the learning outcomes of today's lesson. To define obesity and explain its importance in public health, understand biological and environmental determinants, identify diagnostic criteria and classifications, explain pathophysiological mechanisms linking obesity, assess global and Pakistan specific epidemiology, and apply prevention strategies at population and individual level, and recognize recurrent interventions and emerging solutions. So, what is obesity? Obesity is a major non communicable disease and risk factor for diabetes, cardiovascular diseases, cancers, and many others. Rapidly rising in lower middle income countries, including Pakistan, it is affecting adults, adolescents, and children. It is driven by nutrition transition, urbanization, and sedentary lifestyles. According to WHO, obesity has tripled nearly three times since 1975. So, WHO defines obesity as excessive or abnormal fat accumulation that presents a risk to health. Usually, body mass index is the common measure, and according to that, overweight is defined as somebody having BMI of 25 to 29.9 kilogram per meter cube, then obesity class 1 from 30 to 34.9 kilogram per meter cube, obesity class 2 as 35.0 to 39.9 kilogram per meter cube, and finally obesity class 3, which is greater than 40 kilogram per meter cube, or it is also known as morbid obesity. This is again a, a representation of the BMI and obesity classes. As you can see here, they have also added the category of underweight, which is BMI of less than 18.5. So, different studies have also come up with the specific cutoffs for the Asian population because the recent advances of the body mass index were based on researches done in the European and American countries. So, for Asia, specific cutouts have been declared recently and they are more relevant for Pakistan. So, for Asian categories, overweight has been defined as anybody having BMI of greater than or equal to 23 kilogram per meter cube. And then obesity is defined as greater than or equal to 25 kilogram per meter cube due to higher metabolic risk at lower BMI. And then we have classification by fat distribution. So, how the fat is distributed around the body, or is it around abdomen or is it around the lower area? It is also another category of obesity. So, we have android, central, or abdominal fat, which is higher cardiometabolic risk profile. And then we have gynoid kind of fat distribution in which the fat is most distributed in hip and thigh region. And the ideal waist circumference is for to define obesity for men is greater than 90 centimeter and for women is greater than 80 centimeter. This is an again a representation of the pear-shaped or apple-shaped fat distribution or central or you can say gynoid distribution. So as you can see in the on the left side in the green figure, the upper body fat and the lower body fat are disproportionate. There is more present in the lower body. So this kind of fat is supposedly slightly cardioprotective and it is can be due to many reasons. And then we have apple-shaped fat distribution, in which there is central obesity, which is due to dysfunctional adipocytes, and it has many harmful effects, including cardiac effects. So, what is the pathophysiology? Chronic positive energy balance. Positive energy balance means that you are taking more calories than you are spending. So, chronic positive energy balance leads to fat accumulation. Then we have adipocytes, which will increase in size, and adipose tissue will start dysfunctioning. This all leads to insulin resistance, low grade inflammation, hormonal dysregulation, leptin, ghrelin, increased oxidative stress. This is an again diagrammatic representation of the same process of fat distribution, pathophysiology of obesity. When we take high fat intake, and even healthy people will start developing fat accumulation in their cells. This will lead to dysfunction of adipocytes and then adipose tissue, which will lead to pro-inflammatory cytokines, different factors, and finally it will lead to increased insulin resistance, increased leptin resistance, dyslipidemia, pancreatic cell deficiency, and so on. And then finally, we have effects like cardiovascular diseases, type 2 diseases, liver diseases, and so on. Obesity contributes to dyslipidemia, hypertension, endothelial dysfunction, altered gut microbe, and pro inflammatory cytokines like TNF alpha and interleukin 6. We have now etiology and determinants. There are multiple determinants and for obesity, and therefore it is known as multifactorial. We have genetic predisposition, diet, which include high caloric, high processed, sugar sweetened beverage, etc. Then we have physical inactivity, environmental and social factors like urbanization, food, deserts, and different environments, increased screen time, and increased sedentary jobs, which is very common these days. Then we have behavioral factors like stress, emotional eating, medical causes like hypothyroidism, PCOS, different medications, for example, steroids, antipsychotics, etc. Risk factors include family history of obesity, low socioeconomic status, early life undernutrition or adult obesity, shift work or irregular sleep patterns, reduced breastfeeding, smoking cessation, rapid urbanization in Pakistan. So these are the signs and symptoms. For example, we will be seeing weight gain, central adiposity, shortness of breath, fatigue, different joint pains, snoring or sleep apnea, skin changes like black spots, which are also known as acanthosis nigricans. This is then again a picture showing different symptoms of obesity. It can include like presence of double chin, breathlessness, increased sweating, difficulty in sleeping, extra fat around waist, feeling very tired, snoring, joint pains, reduced sex drive, and high cholesterol level. So these are again some of the effects on the body for obesity. This is an informatic picture by the Cleveland Clinic, which says that metabolic syndrome risk factor, which includes type 2 diabetes, cardiovascular diseases, fatty liver disease, kidney diseases, and gallstones. Then direct effects can manifest in the form of asthma, sleep apnea, obesity, hypoventilation syndrome, osteoarthritis, back pain, and gout. So, according to World Health Organization, International Agency for Research on Science, obesity increases the risk of these following cancers. These includes thyroid gland, esophagus, stomach, kidney, multiple myelomas, pancreas, colorectal, ovary and endometrium, gallbladder, liver, breast, especially in postmenopausal women, meningioma. So, how to diagnose obesity? The main diagnosis is based on different measurements like body mass index, weight circumference, waist to hip ratio, skin fold thickness, which is less common now. And we have investigation like fasting glucose or HbA1c level, lipid profile, especially fasting lipid profile, liver function test for diseases like non-alcoholic fatty liver disease, thyroid function test if clinical suspicion is there. So, how to management obesity? The main management is for lifestyle modification if other complications have not developed. These include dietary modification, so eating in calorie deficit, 500 to 750 kilocalorie per day, high fiber, whole grains, low fat, and reduced sugar. And again, Mediterranean diet or specific diet known as DASH diet for antihypertensive is also recommended. Physical activity increase physical activity to more than 150 minutes per week of moderate activity, and then behavioral intervention like goal setting, self monitoring, counsel, and group programs. So now we come to the management or pharmacotherapy of diabetes. Sorry, of obesity. It includes approved options based on guidelines and availability depending upon different regions. So the first is orlistat. Then we have GLP-1 analogs, also known as, for example, semaglutide. And then we have metformin for metabolic syndrome or diabetes. And we have the pictures of these medicines and injections on the right side. Or semaglutide is also known as the company name is Ozempic, which is very becoming very famous quite these days. So semaglutide is a GLP-1 receptor agonist approved for chronic weight management. It works by reducing appetite, increasing satiety, and slowing gastric emptying. Clinical trials show 10 to 15% or more weight loss when combined with lifestyle changes. It also improves blood glucose, blood pressure, and cardiometabolic risk, and it is considered one of the most effective obesity medications to date. There are key challenges like high cost, long term use is required, and limited availability in different countries. So then we have the surgical management of obesity. It includes bariatric surgery for BMI greater than 40 or greater than 35 with comorbidities. And it has different types like gastric bypass surgery, sleeve gastrectomy, adjustable gastric banding, etc. It is indicated when lifestyle and medications have failed. So now we come to the levels of prevention to apply on obesity. So again, we will be doing the same approach, starting from primary prevention, secondary prevention, and then going to tertiary prevention. Primary prevention. The goal of primary prevention is to prevent the development of obesity before it occurs. It reduces exposure to modifiable risk factors, for example, poor diet, inactivity, sugary beverage intake, and then promoting healthy environment that supports physical activity and nutritious diet. And finally, delaying the onset of metabolic complication like diabetes and hypertension. Primary prevention include um, actions like school-based nutrition programs, restricting marketing of junk food to children, taxation on sugar-sweetened beverage, which is also known as sugar tax, mass media campaigns promoting physical activity, urban planning, for example, making sure that there are parks and walking tracks present, encouraging breastfeeding in the woman, healthy school canteen policies, and community kitchens promoting low cost, healthy foods. Then we come to secondary prevention. The goals include early detection of overweight or obesity through screening, prevent progression from overweight to obesity, identify and address complications early, for example, in prediabetes or dyslipidemia stage, and then initiate prompt treatment to reduce long term disease burden. It includes actions like routine BMI and waist circumference screening at primary health centers, workplace wellness program with regular screening, school-based growth monitoring, for example, height and weight charts, screening high-risk groups like people with PCOS, family history, gestational diabetes, sedentary job, etc. Early lifestyle counseling for overweight adults, early management of metabolic syndrome, and referral system for elevated BMI cases. Then we come to tertiary prevention. It includes actions taken after obesity and its complications have developed, aimed at reducing disability, preventing further deterioration, and improving quality of life. The goals include limiting disability caused by obesity related diseases like diabetes, cardiovascular diseases, and non alcoholic fatty liver disease, improving functional status and reducing complications, preventing recurrence after treatment like post bariatric surgery, and enhancing quality of life through multidisciplinary management. Now we have actions like bariatric surgery and post-operative rehabilitation after these surgeries, and then management of complications like hypertension, type 2 diabetes, sleep apnea, osteoarthritis, NAFLT, and multidisciplinary care of physician, dietitian, psychologist, etc., coming together and managing the weight of the patient. Weight maintenance program after significant weight loss, support groups for long-term behavioral change, and physiotherapy for joint pain and mobility. Cognitive behavioral therapy for emotional eating. Now we come to global burden of obesity. So, obesity has tripled since 1975. More than 1 billion people are affected now. It includes adults, adolescents, children. Rapid rise in low and middle income countries due to urbanization, processed food, and sedentary lifestyle. Major driver of non communicable diseases, as we have mentioned previously. Significant economic burden, 2 trillion US dollar annually. This is the estimated burden of obesity due to healthcare costs and productivity loss. So, what are the global trends and impacts? Children and adolescents among the fastest growing groups in the world. Higher prevalence among women in many regions. Obesity contributes to poor quality of life, stigma, mental health issues. Health systems face pressure from long term management, for example, like diabetes, pediatric care, medications, and so on. So, this is a map of the world which is showing the share of adults who are overweight or obese in 2022. And overweight is defined as the body, according to the body mass index, which I have explained below. So the dark blue color is representing the countries in which the prevalence of obesity is more than 80%. And similarly, slightly less shades are showing similarly low percentage. So first of all, we come to Pakistan, which is showing about 55%. It's mentioned here. Then we come to this is North America and this is Saudi Arabia. So you can see these both countries, and this is Egypt also. So these three countries have the highest percentage of obesity or overweight adults in the world. Followed by this is Brazil in South America, and you can see South America is also generally the whole is slightly shade of dark blue. And then we have in India, our neighboring country, the percentage is way less. It is about 29%, nearly half this percentage of Pakistan. And similarly for Australia and Russia, we have also have high percentages. So this is showing the share of children who are overweight or obese from 1990 to 2024. So you can see in 2000, fairly all the children were of like less than 10% or even less than 5% of the children were obese. So now you can see there is an exponential rise in Australia, and now the current percentage of Australia with obese children is 26%, which is the high, which is for the high, like the highest in the world for any country. Then we have United States with 10% of the children as obese, and you can see India and Pakistan are doing fairly well. But all these studies depends upon the data and the researches which are done in their own countries. So the however good the data is, the results will reflect those changes. So according to this website, Our World in Data, Pakistan is having fairly less amount of children who are overweight or obese. So now we come to the national burden of Pakistan. And in this, as I just showed you in the map, overweight or obesity is among like 50 to 60%, and it rapidly rising in both men and women. Increasing childhood and adolescent obesity, especially in urban private schools. Key driver include high intake of oil, fried foods, and sugary intakes, sedentary lifestyle, and limited physical activity, urbanization, fast food culture, socio-cultural restrictions on women's physical activity. So, obesity is strongly linked to rising type 2 diabetes, 26% prevalence, hypertension, PCOS, non-alcoholic fatty liver diseases. And then we have double burden of disease, which means undernutrition and obesity in the same household. Economic strain on public hospital managing chronic NCDs, and then policy gaps, weak regulation of sugary drinks, junk food marketing, school nutrition program, limited NCD screening in primary healthcare centers. So now we have recent advances. So this is an article which was published in 2025 in Elsevier. It says obesity, prevalence, causes, consequences, management, preventive strategies, and future research directions. So again, the article is saying that we have over 1 million people classified as obese in 2022, which is around 13% of the global population. The increasing burden of obesity is associated with alarming rise in non-communicable diseases, including type 2, cardiovascular diseases, and multiple cancers. Collective contribution to over 5 million deaths annually. Obesity is driven by complex interaction between genetic, behavioral, environment, and socioeconomic factors, with rapid urbanization, globalization accelerating the consumption of high caloric and diet sedentary lifestyles. We have over 70% of obese, unfortunately, living in lower middle income countries and lower income countries, which are also defined as developing nations. And the project estimating a global financial burden of 4.32 trillion by 2035, equal to 3% of the global GDP. This is a diagram, this is a figure which was taken from the same research article, in which they identified these triggers as the principal factors leading to obesity worldwide. These include psychological factors, biological factors, lifestyle, socioeconomic factors, individual behavioral factors, different health factors, socio-demographic factors, environmental and social factors. So again, the recent advances include semaglutide trials. First trial is known as SELECT trial, which assessed the effects of semaglutide on cardiovascular outcomes in people with overweight or obesity but without diabetes. So it was published in 2023, and the SELECT trial demonstrated that once weekly semaglutide 2.4 milligrams significantly reduced the incidence of major adverse cardiovascular effects or events, including cardiovascular death, non-fatal heart attack, or non-fatal stroke by 20% compared to placebo. Similarly, long-term results showed that further analysis that the cardiovascular benefit was independent of a patient's starting weight and sustained for over 4 years. So this is how far they have come. Another trial which was done for weight management was known as STEP trial, also known as semaglutide treatment effects in people with obesity. Trials have evaluated semaglutide for chronic weight management. So there were different steps, and first step was showed that 2.4 milligram once weekly semaglutide combined with lifestyle intervention led to sustained clinically relevant weight reduction in adults with overweight or obesity. Then we have a step 5 study, which was a 2-year study demonstrating sustained weight loss with semaglutide 2.4 milligram versus placebo over 104 weeks in adults with overweight obesity. Similarly, we have step teens trial and other trials. So now we come to the multiple choice question part. A 32-year-old woman in Lahore has a BMI of 27 with central obesity, family history of diabetes. Which is the most appropriate primary prevention measure? A. Orlistat prescription. B. Bariatric surgery. C. Community level physical activity campaign. D. Daily insulin therapy. Or E. Hospital admission for fasting glucose monitoring.
C.
C.
Yes. So the BMI is in the, even by the usual standard, it is in the overweight category. So the first one is to start with the physical activity. A district identifies increasing adolescent obesity linked to sugary drinks in school. Which policy level secondary prevention action is most appropriate? A. Mandatory BMI screening in schools. B. Subsidizing junk food vendors. C. Encouraging morning assemblies. D. Providing free sports uniform. Or E. Restricting water dispensers in school.
A.
Yes. So, as we have also read in school health that at least yearly screening or yearly health checkups or at 6 months should be done for all the children attending schools. A shopkeeper with BMI 33 presents with fatigue and snoring. His fasting glucose is 160 milligram per deciliter. What is the most likely pathophysiological mechanism? Excess thyroid hormone, leptin deficiency leading to hyperphagia, insulin resistance due to visceral adiposity, increased heat loss from brown fat, and increased growth hormone secretion.
C.
Yes, the answer is C, insulin resistance. A peri-urban primary healthcare lack obesity screening tools. Women often presents with obesity-related complication. Which health system intervention would most improve early detection? Installing exercise machine, introducing BMI and screening at primary healthcare center, increasing number of inpatient beds, building a bariatric surgery unit, or hiring only male doctors.
B. B.
Yes, screening again, we will go with the primary prevention at screening at population level. A 45-year-old man with morbid obesity and heart failure requires long-term care, which is an example of tertiary prevention, community-based diet education, pediatric surgery follow-up rehabilitation, workplace nutrition posters, screening his children at school, mass media campaigns.
B.
Yes, the answer is B. As he is morbid obese, and so this is the level of tertiary prevention after pediatric surgery. A school in Karachi reports rising childhood obesity. Dietary assessment shows daily consumption of sugary drinks. Which measure is the most effective for population level intervention? Ban sugary drinks in school canteens, provide weekly vitamins, increase homework hours, replace math classes with physical activity only, introducing daily fasting checks.
A.
Yes. Yes. So, sugary drinks should be banned in schools and even in the surrounding areas nearby of the schools. A tech company finds high employee obesity rates due to sedentary work, which is an effective secondary prevention action. Annual free bariatric surgery, on-site BMI and health.
Recording in progress.
And sorry. Okay. So where were we? Which is the most effective secondary intervention for a tech company which finds its high employee obesity rates due to sedentary work, annual free bariatric surgery, on-site BMI and waist circumference screening, firing overweight employees, reducing computer usage, or increasing office air conditioning?
B.
Yes.
B.
Yes, again, on-site BMI screening is the most appropriate. A woman with high PCOS and BMI 31 struggles to lose weight. Which pharmacological option is most evidence-based? Starting orlistat, paracetamol, high-dose steroids, vitamin C, or antibiotics?
A.
So orlistat is the new drug which we have studied about, just that is the best for the weight management. A 55-year-old man with BMI 41 and uncontrolled diabetes, despite lifestyle changes, seeks treatment. What is the best next step? Sleep therapy, bariatric surgery evaluation, mass media education, increasing dietary protein alone, or stopping all physical activity.
B.
Yes, as the BMI is above 41, so we will start consider the option of surgery. A community with high obesity rates reports heavy marketing of fried food near schools. Which population level primary strategy is most effective? Hospital-based cooking classes, restricting junk food advertising near schools, prescribing GLP-1 agonist widely, hiring more school guards, encouraging children to skip lunch.
B.
We should a restriction should be placed on junk food advertising near schools. This is the MCQ answer key, and this video will be uploaded on the YouTube channel of Institute of Public Health. And thank you very much for listening.
Thank you very much, Dr. Taimia. Very nice presentation, and especially the recent advances that you have mentioned. I must appreciate it. However, please also introduce a slide of recent advances before giving the recent advances.
Yes, ma'am.
The whole trial is about the STEP trial and especially the STEP teen trial
Yes, ma'am.
and the semaglutide efficacy and treatment trials. They are the recent updates,
Yes,
and we
ma'am.
know that now we have liraglutide and other important things that should also be in recent advances.
Yes,
So
ma'am.
overall, it is a very good presentation. I must appreciate it
Thank you,
and
ma'am.
keep it up. Thank
Thank you very
you.
much, ma'am. Thank you, ma'am.